I'm sure we have lots of questions.
May I ask one question?
Yes, please.
This is to Dr. Om Ganda. Do you see bempedoic acid replacing statins in the future?
Bempedoic acid?
Yeah.
I don't think that we can say that at this point, because all said and done, statins have the best record, right? They are now cheap. 6 out of the 7 statins are generic, so cost is not an issue. They have stood the test of time. And in fact, we have 20, 30-year follow-up data from some of the statin studies that have shown that they have a long-term safety. And I think obviously you cannot dismiss that. So I don't think that they will be replacing statins anytime soon. Moreover, the bempedoic acid currently is undergoing randomized clinical trial for cardiovascular events. So even if that is positive, I would still say combining bempedoic acid after statin with or without ezetimibe will be the next option. But of course, in selected cases, when the LDL is quite high, PCSK9 will still be overall a better approach in efficacy than bempedoic acid.
Thank you, sir. If I can ask you one very tricky question, which was bothering all of us, about reduction of LDL cholesterol to a level that, in fact, there was a couple of articles that if you chase cholesterol too badly, there are problems with cognitive functions. And in fact, there were, crimes against self, suicides, and crime against society, homicides. The actually incidence of these crimes increased as the cholesterol came down. In fact, that was a very high criticism. So I don't know what is your take on that, because we are really afraid because of cognitive functions are quite dependent on your cholesterol level.
Right. So your question is, something that has been going on for a very, very long time. You would recall that even before statins came out, when we used to use these bile acid exchange resins, and we used to use high-dose niacin, this question came up, and some of the epidemiological not well-controlled data, because very difficult to control for everything, this question was raised. And there was a marginal increase in some of the observational studies, but none of that panned out in the randomized control trials, starting with statins. Look at the heart protection study, which was a huge study with simvastatin in UK, which started changing the whole conception about the lower LDL cholesterol. So go after the risk, not the level. So I think that started the whole story. And none of these randomized control trials, we have found any evidence of that. And I mentioned that particularly the evolocumab study, the 4-year trial, 27,000 patients, they made a lot of effort. Actually, it's a separate study called Ebbinghaus study, also published in New England Journal soon at the same time after the trial came out, where they looked at major batteries of neurocognitive tests. But you can argue, and I have no answer for that actually those studies were 2-year-old. They lasted only 2.5 years. So do we need longer time? So that is actually currently being done. Some of these patients are being followed because we need long-term data. And of course, the mean age in these studies was in the 60s, which is actually, somewhat reassuring. But we need to do a separate study in older people, because people are living longer, and neurocognitive defects are more likely to happen in older people. So I would like to see a study where people above the age of 65 to begin with are recruited and then followed for at least 5 years. Fairly large number is needed to make that point. So I think even though overall this point is still an open point in older people, but I think we're getting more and more evidence of the lack of toxicity from neurocognitive point of view. The other point I think your question brings up, how much cholesterol do we really need? Okay, I'm not saying that everybody should be going down to 30 or even 40. And I know that in India, people have tried to come up with their own guidelines recently. And they said we should go even below 50 or even below 40, which I think is probably a little bit unnecessary at this point. Think about people with familial hypocholesterolemia or familial hypobeta-lipoproteinemia. These are families where naturally they have LDL cholesterol under 30 all their life. They have no problem in hormone synthesis, bile acid, gonadal steroids, or any other, corticosteroids, for example. So we don't need that much cholesterol around to do some of the essential function. And they don't have any neurocognitive problems that's been looked at. But again, those are a very small number of people who are born with very low LDL cholesterol. Okay, that's the only example where you can think about a rare syndrome of hypobeta-lipoproteinemia with LDL cholesterol below 30.
Thank you very much, sir.
Older people, better study of neurocognitive function is clearly needed and will be forthcoming.
Because even Alzheimer's disease is now considered as type 3 diabetes.
Yeah.
In fact,
right.
We have so much of data on Alzheimer's disease, although we don't have many cases of Alzheimer's disease.
You are absolutely right that the risk of Alzheimer's is increased in diabetes, and the risk of diabetes is increased in people with Alzheimer's. So it works both ways. And it's not just the APO3 that is associated with Alzheimer's.
Thank you, sir.
Welcome.
Archana, there are some questions in the chat for Dr. Mandeep.
Yes.
Yeah.
Right. Dr. Plierma has asked a question that weight loss with low calorie diet is effective in burning liver fat. Does TZTs and weight loss diet may be as effective as a combo of GLP-1 and TZT? To Mandeep, sir.
Yeah, that's an excellent question. So, certainly very low caloric diets have been shown with weight loss to really dramatically reduce liver fat. And so then the question comes, can you combine TZDs with a weight loss diet and get the same result as a GLP-1 and plus a TZD? So, it takes me back to when TZDs came out, and so one of the hypotheses was that the way TZDs work is by enhancing adipocyte differentiation. So weight gain has to be a part and parcel of TZD therapy. And then a study came out where they showed that you can ameliorate the weight gain with TZDs by doing a very low caloric diet or a low caloric diet. The issue here is long-term. The management of NASH is long-term. And long-term, these low-caloric diets may not have a sustaining effect. It's hard to sustain them, right? And then the second issue here is, okay, GLP-1s plus TZDs, after all, are we just getting the effect of weight loss, appetite reduction, and a TZD? So my answer there is, you're probably getting more than that. I agree with Guillermo that this is a study that needs to be done, but certainly, as I showed you, the data with GLP-1s, you're probably also getting a direct effect on hepatic fat oxidation, independent of weight loss and independent of reduction in appetite. And that may be the key here in terms of getting additional benefit or being more effective than TZD plus weight loss. But that's an important study to conduct, I think, Guillermo, to really answer the question, are the effects of GLP-1 beyond just weight reduction and appetite reduction? That could be a very good study to do. And the other question, impressive pilot data combining GLP-1 plus TZD. Are you aware of any long-term studies using this combination? As I said, I'm not aware of even a single study combining pioglitazone with GLP-1 right now. So the only data we have is from our so-called pilot study combining exenatide with pioglitazone.
That's good answer. Yeah.
May I ask a question?
Sure.
So this is to Dr. Ganda, sir. We have a very strong data on therapeutically targeting LDL in people more than 40 years of age. But I don't think the data is so strong for people younger than 40 years. And now we are dealing with a lot of people who are at risk with LDL. So is the recommendation or guidelines similar to people who are younger than 40 years? Not those who are with FH, but definitely I think we are better, we're more confident in them. But in otherwise people less than 40 years of age?
Yeah, very good question. This question is a very important one, because the only reason the indication for statins and other drugs is to start at age 40 is simply because the clinical trials included people above the age of 40. It doesn't make any sense, because atherosclerosis actually begins in childhood. And, so the biology of atherosclerosis is much more better understood, let's say, than the whole issue of the age at which to start statin. So we were lamenting about that, and we knew that that was not the right thing to do, to wait until age 40. Speaking of diabetes, actually, both type 1 and type 2, in fact, younger people, and there's a lot of good evidence now from Scandinavia, from other long-term observational studies, that younger people, even if you adjust for the age and duration of diabetes and other risk factors, they have a greater atherosclerotic burden. The younger you are, the greater the burden. And some of these may have to do with, adolescents and school children smoking and whatever, but you can never adjust for all those things. But thankfully now, starting in the 2019 AHA guidelines, and now also endorsed by the ADA and European guidelines, it has been clearly stated that people below the age of 40 can be started on statin if they have type 1 diabetes for 20 years or longer and other risk factors, or type 2 diabetes who have diabetes of 10 years or longer with multiple risk factors. So what does that tell you? If you develop type 1 diabetes at age 12 or 10, you have to be 30-year-old. That's not much better. And not everybody gets diabetes at age 10. Some get at age 20. So that again brings you to age 40. So again, I think it's a slow progress, because there's never been a good study in the younger age group, and that needs to be done. But even type 2 diabetes, people are getting type 2 diabetes at younger and younger age, as you know, in India, everywhere in the world. Look at our populations here. Mandeep, I'm sure, mentioned, and Dr. Guillermo may have mentioned that, we have so many Latinos and African Americans, and data is a lot of data from Mexican American studies where diabetes occurs at such a young age, type 2. So they are at risk. So I would say, if you have multiple risk factors, including, don't forget, early CKD, just albuminuria. You don't have to have drop in the GFR, because there's plenty of evidence that microalbuminuria is a risk marker for cardiovascular disease. And not everybody with microalbuminuria goes on to develop kidney disease. So I think those are the kind of criteria one should think about. The other side of the coin is also true, that the guidelines say age 40 to 70, simply because those people above the age of 70 were not included. And I'm a very big fan of treating people who are older if there's a good reason to do that. Okay, so I'm not as young as I used to be. So you can imagine my interest in that field. So again, is there a clinical trial above the age of 70? None. There's no trial. But there are two large trials currently in progress. One is called the STARI study, which has been underway for 2 or 3 years. We should be getting the results soon. They are only including people above the age of 70, I believe, and following them for about 8 to 10 years. And the endpoint is not cardiovascular events necessarily. They are watching cardiovascular events. The main endpoint is cardiovascular or total mortality and cognitive function in these people. So going back to Dr. Baraska's question, the second study actually that is being done in the older people is actually started by the NIH just about a year ago. So it'll take several years to complete that. But we need both of those studies for older people. So right now the guidelines say secondary prevention, of course, there's no debate. In primary prevention, if you have somebody on statin, and they reach the age of 70, 75, doesn't mean you need to stop it. But whether to start it is a different question. And that's the question that is being studied. Finally, since it's such an important question, they actually did 2 studies now, one in France and one recently published, I believe, in JAMA, where they took people above the age of 70 or 75, I don't remember, 75, let's say, and those who are on statin, they were randomized. One group continued the statin. The second group, they stopped it. So withdrawal of statin above the age of 75. And within 2 years, they had an answer. Those who were discontinued actually had more cardiovascular events than those who continued. But these are, again, not properly done RCTs. They're more of, combination of some observational element in that. So I think, they're prospective studies in that sense. I shouldn't say RCT, they're prospective observational studies, but we're still waiting for the other 2 studies. So I think I think you got to look at the patient. What do you mean by older person? Now, that's the other question that comes up. Who is old? Okay, so again, like we use the guidelines for glycemic control, it's not the age that matters, it's the functional level. Okay, and you and I can, I'm sure, point out many people above the age of 80 who are quite healthy, who have no disability, and they certainly would look forward to living another 20 years.
Yeah.
And then there are some at age 65 or 70 who had a lot of disability and frailty. And actually there are guidelines now that if you project somebody's survival time less than 5 years, then maybe you can discontinue statin. Certainly if it is less than 3 years. But because, older people tend to have higher incidence of adverse events.
Sir, I have to say something.
Yeah.
A guru is always guru. And after I heard you today, I have realized that I had to catch up with a lot of reading. I still have to read a lot. And I think
there is a lot to read. There's a lot to read. Think about all the other trials that you'll hear about or heard about, all the GLP-1 trials and SGLT2 trials. I was counting actually yesterday because we had the AMPA Preserve trial just came out. So there are now 9 GLP-1 RCTs and there are 8 SGLT2 RCTs, not including the SGLT1 trials. So you are absolutely right. I mean, that's what keeps us going because you have to keep in touch, keep learning more about this, and our learning threshold really keeps on rising. So
thank you.
And I
thank you so much.
Do
we have some more time?
Yeah, we do. I had one question, if I may.
Sure.
Again to Dr. Ganda. We looked at the risk by using the ASCVD risk score, for example. And we talk about a 10-year risk. But while initiating statin, our criteria are different. That is, for statin initiation, we use the LDL, and then we say we don't chase numbers. So when somebody is at an intermediate risk and you use a moderate intensity statin, unless you chase numbers, how are you going to re-stratify the risk?
Yeah, I mean, again, I think all of these risk calculators are only suggestive. None of them is really something to be taken too seriously. That's my opinion. We had the Framingham risk equator for risk equation for a very long time. Now we have the NIH, the risk calculator that is called the pooled risk equation, PRE. And look at that. What kind of things they ask you for? They ask you for age. They ask you for gender, they ask you for your cholesterol level, but they don't ask you how long have you had diabetes. So whether you have diabetes for 2 years or 20 years makes no difference according to this calculator. You just don't just ask DM plus or minus. UK PDS try to do a little bit better. They have their UK PDS engine. As they call it, they do have diabetes as a factor, diabetes duration, but that's not been very popular. So in some cases, these risk calculators overestimate the risk. Sometimes they underestimate the risk. They probably underestimate the risk to some extent in Indians, for example. And it is suggested that whatever the risk equation calculator tells you, multiply that by 0.5, 1.5, so 50% higher, just because of studies like the study that was done in India by Yusuf and others, showing that MI occurs at a younger age. The other thing in that risk calculator, all of these risk calculator, particularly the NIH one, they ask you a question: are you white or are you black? So if you are not black, you are all white, according to this risk calculator. So I mean, that makes no sense. So we need to develop better risk equations and populations. The huge population in South Asia, the huge population in Mexican or Latin American people, for example, there are no such calculators. So I think these calculators are suggestive. And the final thing is that if you have a person, let's say a younger person, and you are kind of confused because the risk equation tells you that risk is, let's say, 7% or 10% in the next 10 years for primary prevention. And so you're stuck. The only recommendation then is, if you really want to be sure, do a coronary calcium score. Now, I don't know how frequently you guys are doing it. Even we are not doing it very often, particularly in people with diabetes. This is for primary prevention in non-diabetics. And how does it help you? If the calcium score is 0, then you can wait, do another score 2 or 3 years later. But if it's anything above 0, you got to start statin. Okay, so I think that's a useful, and there are studies that have been done that you can reassign the risk by adding the coronary calcium score. And I wish that this will become a commonplace. Right now it's not covered, so we don't do it routinely, particularly in people with diabetes. But even in people with diabetes, coronary calcium score does make a difference in the absolute risk, and you can reclassify based on that. I think there was another question I just saw come up on the chat box. Was it Guillermo or somebody else?
It was about pre-diabetes, I think.
Yes.
What's the question? Can you read it for me? I can't see it.
Yes. Pre-diabetes is not included in risk calculations. Why? Should we consider pre-diabetes as similar risk factor as a diagnosis of diabetes?
Yeah, another good question. It is not included. It depends on how you define pre-diabetes. And I'm sure that you can show me people who are labeled as pre-diabetes but actually have diabetes. That's a separate question. Because just looking at fasting blood sugar or A1C as the guidelines, even from ADA recommend, you can miss some people with diabetes. You don't do glucose tolerance test anymore. And in older people and in Asians, 2-hour postprandial may be already in diabetes range than other populations. So I take pre-diabetes seriously, and there's data now from pre-diabetes populations followed over a long period of time that the risk is not as high as people with type 2 diabetes, but certainly higher than people without pre-diabetes.
Even
So
non-diabetic hypertensive people are included in pre-diabetic. A purely hypertensive patient with a normal blood sugar is also now considered as a pre-diabetic.
Yeah, I think particularly if their triglycerides are high, I would say. So I use the triglyceride as a marker of insulin resistance in such people.
I think
I will watch them more frequently.
Yeah, I think once you exceed a A1C of about 5.5, your cardiovascular risk just starts to take off, and it's a continuum. So, there's really very hard to put any number cutoff here.
Yeah.
Nita?
Yes, sir.
Can we say goodbye?
Yes, I'm very happy to tell you that even at this late hour, we have more than 2,000 people logged in. So it has been an interesting
Wonderful.
discussion.
That is because of some stalwarts are talking. That is the reason.
Right.
No.
Thank you so much. You're very kind. And it was really wonderful to join you and enjoyed the audience participation and your questions.
Thank you.
And hopefully we'll do it again.
Bye-bye.
Thank you so much.
Bye-bye, Manjit.
Bye.
Thank
Bye.
you.
Thank
And
you.
Thank
we,
you. Thank you very much.
Thank you so much.
we end today's session on a very high note, and we hope we'll have you back again at 10 o'clock in the morning. So we look forward to welcome you tomorrow at 10 o'clock for the next day's sessions. So
We have our quiz lines open till 12 midnight. Do not forget to log in for some very exciting prizes. The quizzes will be different tomorrow and again different the day after. So till 12 midnight, the quiz lines are open.
thank you. Good night.
Good night.
Good night.
Good night, everyone.
Good night.